So good morning everyone. Starting the next session, it's refractive aspects in cataract surgery. So I would ask everyone to settle down please. So cataract surgery has come a long way where it has become a refractive surgery since we are using a lot of premium IOLs and dealing with the various aspects of it. So this IC is basically some practical tips to sail through using premium IOLs and getting a good results from the patients. So I'm thankful to my co-speakers and co-instructors here. So I'll be beginning the session with my talk.
So Dr. Vanishri will be talking on understanding the higher order aberrations and role of aspheric intraocular lenses for better outcomes.
Yeah, so we are using aspheric IOLs since more than a decade now, but many a times we not really understanding what these aspheric IOLs are really doing, what were they developed for. So I would just like to cover up what are the aberrations that we deal with in every patient and how we are trying to reduce the effects of these aberrations in the eye so that we give a good outcome to the patients. So higher order aberrations and how the aspheric IOLs are having a role in cataract surgery. So in cataract surgery, or rather now refractive cataract surgery, we need to understand the overall optical aberrations of the eye to find out the best suitability for the patient needs and what suits the patient. We are using a lot of premium IOLs, multifocals, trifocals, EDOFs, torics, but how do we really plan for the patient depends on what pre-existing conditions are there in the patient. So very basically, what are these aberrations in the first place? So they are lower order aberrations. The 90% what we have is defocus, that's your myopia and hyperopia and astigmatism. And 10% are the higher order aberrations, which is spherical aberrations and coma. These are practically relevant to the general population. Now, a perfect optical system that does not exist in the eye, but a perfect optical system is the one which is not having any aberrations. So, a wavelight, when it is passing through optical system, it is going to get aberrated. If you can see that, if you can appreciate the diagram, so that it does not focus to a point. So, it will have a spread. So, this wavefront which is going, which is like, like a not a perfect curve, will have some undulations. So these need to be measured. So that is what we are doing when we are measuring the wavefront aberrations. So we are doing that with the help of wavefront aberrometer. So there are two types, Hartmann-Shack and the sharing type. So here you can see the 3D map of it, of wavefront, how that is getting formed. So now we need to quantitate it. We are seeing it as a wavefront, but how do we quantitate it? How do we actually use it? So we quantify it using the Zernicke's polynomials. So these are mathematical equations. Again, they look very daunting to us. But the idea is that the wavefront, which is the reference plane, is going to be in green. The part of the wavefront which has gone beyond is red, and the part which is behind is blue. So diagrammatically, we get an idea that how the wavefront looks. But it is quantitated using root mean square error. That is the average deviation of the measured wavefront from the ideal optical system, which will not have aberrations. And the second system is the Fourier analysis. So Zernicke, I won't go into the very details of this. So if you see this diagram, so the perfect wavefront, if it is a straight line, so some aberrated wavefront, part of it is ahead, so that is calculated as plus. Some will go in minus, again some in plus. So we take a root mean square of these aberrations so that the minus and plus values are gone and we have a finite figure with us. Now there is a very nice instrument called the iTrace, which gives wavefront analysis, it gives the topography, it gives us the keratometry readings, autorefractor, pupillometry, everything put together so that we can analyze these aberrations well and use it practically when you're planning a cataract surgery patient. Not everyone will have access to iTrace, so even the basic tomographers like the pentacam will give us the wavefront analysis, the root mean square value of the aberrations which are practically relevant to us. So this is how the iTrace readings look. So the most important one is the spherical aberrations in our practice. This is the fourth order aberrations, and why it is important because every eye is having a natural spherical aberration which is 0.1 to 0.55 microns, and it aids us in depth of focus actually. It gives us some depth of focus. So the average spherical aberration of the eye is plus 0.27. Now why it is important? So how it helps? Now if you see this diagram, right bang in the center, there's no spherical aberration. So here the image will be very crisp with maximum contrast sensitivity, but there is no depth of focus. So you go slightly beyond negative spherical aberration and positive spherical aberration in the tolerable range up to minus 0.35 microns. You have some good depth of focus with a slight, contrast sensitivity decrease, but that is tolerable. And there is a range which is up to non-toxic. So here you'll have maximum depth of focus and it will still be non-toxic. So that depth of focus will actually aid in your near vision. And beyond that is a toxic range, where the spherical aberration is so high that it is going to cause glares, halos, and those issues. So this range of 0.6, minus 0.6 to plus 0.35 is the neural adaptation range, which this spherical aberration is actually going to help to keep the image clear for near, giving a depth of perception. So this diagram again, explains the same thing, that when there is a sharp focus at one particular point, only when the image is focused at that point, the brain will perceive it as a clear image. And if the image goes out of focus, the brain will see it as fuzz. So there's no depth of focus here. But if you have some spherical aberration, so what is happening, you're getting a range of vision. So when the object moves in that particular range, you'll have some depth of focus and the image still remains clear. Now, how does it apply to cataract surgery? So what happens is, in a young patient, actually the cornea is having a positive spherical aberration. The lens actually gives a negative spherical aberration. So totally there's no spherical aberration and the image quality is very sharp and clear. In the middle age, say around 45 years, the cornea is still having the positive spherical aberration. The clear lens, the spherical aberrations have almost come to zero. So there is a overall total mild positive spherical aberration, which is giving an increased depth of field, where the accommodation is slightly getting lost now. Now in an aged eye, where there's a lot of cataract present, both the cornea and cataract are going to give a large positive spherical aberration, so the image quality is going to deteriorate. Now what happens when you put a standard IOL? Now a standard IOL has a lot of positive spherical aberration. So the total positive spherical aberration becomes quite a lot, so the image quality is going down. If you use a zero spherical aberration IOL, they have a mild positive spherical aberration. So they'll have little depth of field, but still the quality of image is not very sharp. And a negative spherical aberration IOL, what we call as the aspheric IOLs, these are the zero aspheric IOLs and the negative aspheric IOLs, they give the maximum clear image, but the depth of focus will be lost. So how does it actually affect? So this is a diagrammatic representation of if you're using a spherical IOL, then that's how the image quality is. And compared to an aspheric IOL, you get a sharp image. So traditionally, the IOLs are positive spherical aberration, zero aberration, and negative aberration. So in aspheric IOLs, basically the thing is the spherical IOLs, they have a same power on the lens. So it causes not a single point of focus. They're easy to make, but they'll have a lot of positive spherical aberration. Whereas the aspheric IOLs are more difficult to make, but they'll give you a sharp focus on the point. So that's why they give you a sharper clarity, but depth of focus is lost here. So the same thing again. So where does it apply now to us is, many patients are going to be your post-refractive surgery patients. In the future decades, we'll be having more patients who will be having patients who have had refractive surgery rather than having virgin eyes. So it is important to make sure that you find out what kind of LASIK the patient has undergone. If it was a hyperopic LASIK, then the cornea is going to become more steeper here. It's a hyperprolate cornea. So the cornea is already having a negative spherical aberration. So here you should not use an aspheric IOL and use a standard IOL. Whereas in a myopic LASIK, it's a flat cornea. It has a lot of positive spherical aberration. So here your aspheric negative IOLs help. So coming quickly to the examples. So negative spherical aberration IOLs are your Technis, Vivinex, Alcon, Acrysof ones. And zero aspheric IOLs are your Bausch & Lomb, Envista. And traditional IOLs are your Sensor and the other lenses. Take home points, target the lower order aberrations first, then focus on the higher order aberrations. Important higher order aberration is spherical aberration. Do the tomography to find out the total higher order aberrations. If it is more than 0.4 RMS, avoid multifocals or true EDOFs. And if the chord mu or chord alpha is more than 0.5, then avoid multifocals. Thank you.
Thank you, Dr. Vanashri. So just before you leave the podium, so could you just recap Because we are so used to putting aspheric IOLs, what are the patients in whom you would not put an aspheric IOL?
Yeah, so as I said, hyperopic LASIK patients, they have prolate cornea. So there is already a negative asphericity is there. Negative spherical aberrations are high. So if you're going to put a negative aspheric IOL, like your Technis, so the negative asphericity increases more. So you are going to offset it in a bad way. So that's hyperopic LASIK is basically you need to be careful about. Normally patients are having a positive spherical aberration, and even myopic LASIK it is positive spherical aberration. So you are safe to go ahead with the negative asphericity IOLs as well.
Any other cases like multifocal cornea or
Yeah, so other ablations, if they have been done, then you have to actually calculate the spherical aberrations using tomography and then accordingly titrate and use the IOLs.
Thank you very much. So next we'll have Dr. Sai Kumar, who would be talking to us on another entirely new range of IOLs. They're not very new, but they have been moving back and forth between EDOFs and trifocal lenses. So could you please put Dr. Sai Kumar's presentation? So he'll be talking on these particular premium IOLs and how to read the fine print before proceeding with the surgery.
Thank you, Swapna and Dr. Vaneshri, for having me in this session on premium IOLs. I am going ahead of Minu because he is in some other session. Dr. Chitra will also join us soon, so I'll make my presentation. So basically, I'm going to talk about trifocals and EDOFs. We have been hearing a lot about these lenses in the last few years. So read the fine print means just go through the finer details before you implant the lens. Not that you will be able to read fine print if you implant these lenses. So I will be mentioning some brands for the sake of this presentation, but I don't have any financial interest regarding any of these lenses or brands. So what is an ideal intraocular lens that you would like? It's a dream, utopian sort of situation where the commonest question patients ask us is, you have implanted a lens inside my eye. Do I still have to wear glasses? I mean, even after so much counseling, so much of things, people still do ask the same question. Kanninagathu lens undallo, ini njan kannada vekkano. So we are not able to give a proper answer for that. So ideal IOL should be something which corrects everything. Your cylinder, your sphere, your distance vision, your intermediate vision, your near vision. We unfortunately don't have a lens which fits into everything, but we have certain lenses which sort of get us there with some caveats along with that. So how do we go about a patient who has come for cataract surgery, who is keen on spectacle independence? So basically in the present scenario, at least in my practice, I have two options. One is trifocals, where the light is split into three different zones. So there is a compromise in light split. It actually reduces the contrast sensitivity a bit, but on the positive side, it gives you three ranges of vision. So initially when I used to start practice many years ago with multifocals, it was mostly for distance and near. So now with so much of intermediate vision being used, you also have an intermediate vision. The EDOF lenses give a continuous range of vision, not splitting the light at specific points, but giving a sort of range of vision which works from intermediate vision and beyond, but for very close vision, it probably is not a very great idea. So when a patient comes to me asking for spectacle independence, these are the points that I go through normally. The first thing I note is the personality of the patient. How keen is this patient to avoid glasses? Is he or she a very pushy patient who will be unhappy if the results are not good? Second thing is affordability. Affordability does not just mean, about they being able to afford the surgery alone. It's about the way they look at it. I have spent so much money, I'm not getting my result. And two specific professions with whom we have tried this and are very unhappy are persons who do carpentry work and goldsmiths. So these are two people who, although they may not be very affording, they think that if you put this best lens inside the eye, they can do all their work without glasses. So they somehow get money from somewhere and borrow and all and come for a trifocal or an EDOF lens, but at the end of the day they are quite unhappy because the range of their work, the way they keep their wood while they are marking, all those are issues. So these are things as a personality, it's not just about the affordability, whether they will be happy with that particular lens. The amount of refractive error, the slight hyperopes are the most happy patients with a trifocal lens. They are able to avoid glass. Already they are wearing glasses for distance and near, so they'll be able to avoid glasses for both. They are very happy. You have to correct astigmatism in trifocals and EDOF lenses. There's absolutely no compromise on that. Whichever way if it's a small astigmatism, you put your wound in the steeper axis. If you have access to femtosecond laser, you can do. But in my experience, femto lasers correct astigmatism only to about 0.75, max 1 diopter, not even 1, maybe even less than that. Or you have to go in for a toric EDOF or a toric trifocal lens. Only then you will be able to achieve the result. Please don't compromise. You might have done an excellent surgery, put the best trifocal lens available in the market. The patient has got 0.75 or 1 diopter of residual astigmatism. It defeats all the purpose of your lens. Look at the ocular surface very well, because if you have severe dry eye and severe problems on the surface, not great candidates for these lenses. Of course, corneal diseases, retinal diseases, and zonulopathy. So you have an obvious pseudo-exfoliation. Even if there is no zonule weakness at that particular time, these are patients where the lenses can move this way and that way, especially for trifocals. EDOFs are a bit more compromising, but trifocal lenses, if it moves, then your trifocality is gone. So the best candidates are the patients with healthy ocular surface, a very nice and stable biometry, patients with realistic expectations who are saying, okay, but most of the time, will I be able to manage without glasses? Fine. These are the ideal patients who understand what exactly are the visual goals. So the general principles are that you should have a clear ocular media other than the cataract, a normal cornea, a normal optic nerve, and a normal macula. Significant macular disease, irregular astigmatism, keratoconus, and advanced glaucoma are definite red flags where probably you should not implant these lenses. I have had patients with advanced glaucoma who said, I want the best lens, EDOF lens, whatever is the best I want, I am willing to get whatever vision. For them you can. But generally these are the conditions that you avoid. Optimize the ocular surface, obtain a good biometry. If you have significant dry eye, you apply lubricants for some and probably repeat the biometry. As I mentioned before, always correct the astigmatism, and counseling and speaking to these patients are very, very important. Normally in my practice, when I advise a patient for surgery, they go to the counselor, they choose the lens and procedure, and they usually go off. But if it is a trifocal, they come back to me and I spend another few minutes with them and tell them what exactly to expect. So the ideal trifocal candidate is a patient who prioritizes maximum spectacle independence, distance, intermediate, and near visual needs according to their needs, a very active lifestyle so that they don't want to wear glasses most of the time. They are motivated but tolerant to some amount of glare and halos. This glare and halos is something which sometimes we overemphasize, sort of using that as a weapon to dissuade patients from trifocals. I think that should not be done, but they should be told that this is a possibility. You may have it. We can't quantify it, how much you will have, how much you won't have, and things like that. So they are willing to go through an adaptation process, willing for bilateral implantation. That's very important. If you go in for a trifocal, and please tell them, even if there is minimal cataract in the other eye, it's better that you go in for a trifocal in the second eye so that you can maximum depth of focus and utility of these lenses. A good cornea, minimal aberrations. I have found these lenses very useful in patients with dementia and movement disorders. Patients who just can't lose their spectacles all the time. They don't remember where they have kept their spectacles. They have a lot of movement disorders in their hands. Although vision is not too great in them, because we get a lot of central Parkinsonism patients where there is very minimal tremor, but they have a lot of central Parkinsonism. Even if after a very good lens, they find it very difficult to read. I think something to do with accommodation. So although the vision quality may not be very good, the very fact that they don't have to wear the glasses gives them a lot of, I'll take 1 minute more. The poor candidates are the perfectionists, the professional night drivers, patients who are very sensitive to glare and halo. You just put them on the slit lamp, you just shine a torch light and they're like, I can't tolerate this light. probably not a very great candidate because they're going to be very sensitive to this. Occupations which need very, very high contrast, please don't. Even EDOF lenses, some people feel that EDOF is a compromise on contrast sensitivity. So use a normal monofocal with spectacle correction for patients in some occupations. AMD, maculopathy, glaucoma, obviously not too great. So my favorite trifocals, I use a lot of synergy lenses. I also use panoptics. Geometric and Geometric Plus is from Hoya, where you have a combination of Geometric one eye and Geometric Plus in the other eye. And I've also used some eye diff lenses from IOCare, which also I found to be quite useful. The new kids on the block are the Synergy is coming up with a new generation, which is called the Odyssey, that is going to be launched in 2026. They have smoothened out a lot of the rings in the trifocals, and apparently it's got a better profile regarding the glare halos and all. The Panoptics is again coming with their newer version, which is called the Panoptics Pro. They've already introduced it in the US. It's again coming to India early 2026. And the Rainer has just introduced a lens which is called the Rainer Galaxy, which has got a spiral design. So instead of the normal rings, the rings start in the center and they spiral out just like that. So that is a new concept, and apparently it has got very good results. I have not tried a Galaxy so far. Probably I'll do it in the coming 1 or 2 months. Coming to EDOFs, patients who prioritize distance and intermediate predominantly are the ideal candidates for the EDOF. They're willing to accept a small correction for near. They are sensitive to glare and halos, which is almost non-existent in EDOF lenses. Have a bit of ocular surface issues. Post LASIX, generally, in spite of all these aberrations which Vanessa spoke about, I would still go in for an EDOF lens. A very active lifestyle. Dashboard is something which is very, very useful for these EDOF lenses. People who drive a lot at night and things like that, they want to see the dashboard, they get very good vision because that's in the intermediate range. Obviously, they may not be able to read very close, but dashboard vision is very good with EDOF lenses. So these are the main 2 EDOF lenses that I use. The Ksos VVT, which I've been using for about 3-4 years now. And the recent one is the Technis Pure C, which does not have any rings, just make some polishing on the posterior surface, and this also has given me excellent results. So some essential investigations that have to be done in these patients is visual acuity and refraction, obviously, a very good biometry, preferably an optical coherence biometry. I don't use topography for every patient, but if needed, I do. Surface evaluation, always do a macular OCT in these patients. Don't think it's an unnecessary investigation. If you're going in for one of these premium lenses, always do a macular OCT. In many cases, we pick up very subtle lamellar holes, small epiretinal membranes, which is not visible in your clinical examination. Pupil size, just a few seconds I would like to dwell on pupil size. If you have these large pupils, they may have significantly more glares and things like that. Small pupils are supposed to be a problem for the near vision in trifocal lenses. But in Indian eyes, generally we have smaller pupils. The meiosis actually compensates to a certain extent for the loss in trifocality. So I feel small pupil is not a very great problem. And endothelial cell count also is extremely important. There are some metrics which are rarely used, which is the angle kappa and alpha. I think some surgeons use that. We don't use it regularly. We all can get a small compromise on that, which is called the chord length, which is available in the IOL Master 700. So you can use it as a surrogate marker instead of using the angle kappa. So in summary, trifocals and EDOFs are definitely the way ahead. We are going to see a lot of more of these lenses, and I am sure in my surgical career, I am going to see EDOF lenses with no rings, but with 100% range of vision. I am definitely looking forward to that. More and more continuous range vision IOLs are coming up. Patient selection extremely important, counseling extremely important, and always correct residual astigmatism in these lenses. Thank you so much for your kind attention.
Thank you, Dr. Sai. If you'd remain at the podium, I just had a few questions for you. One was regarding implanting, which I think a lot of our practitioners would have. Implanting a multifocal or an EDOF lens in the second eye when the eye first done is already a monofocal IOL. So what are your comments regarding that?
No, there are patients who ask for multifocal in the second eye and claim that at least at one eye I have better range of vision. Generally, I don't promote a multifocal in the second eye. Generally, I don't, unless they are very, very motivated for it. EDOFs are a slightly different ballgame. EDOFs can be intermixed with monofocal lenses. In fact, there are a lot of surgeons who use EDOF in one eye and then probably, give a small minus for the second eye again with the EDOF so that they get a better range for reading. So you can use the slightly minus eye for slightly better near vision, the other for better intermediate and near. So that's something like not typically a mix and match, but something like that. And there are also surgeons who are very fond of monovision. I don't know how many of our surgeons are very, using a lot of monovision lenses, but that is also another possibility with all these, especially these outdoor people who just don't want to wear glasses. Correct one for distance, one for near. If the reading habits are not too high or too long, they can still use a monovision.
Thank you very much. And then the second was regarding the toric calculation that you mentioned. I think that's very important that for all EDOFs and for all trifocals or any sort of multifocality, we need to let them. So do you routinely let all your IOLs of that category go through the toric calculator?
Yeah, we do. See, we have a dedicated optometry team which does only biometry. So they are told that if they have this, and even in the counseling they are told, if they opt for an EDOF lens, they are told that if you don't have astigmatism, you get EDOF. If you have astigmatism, you get an EDOF toric. Similarly, you get a trifocal. If you have astigmatism, you get a trifocal toric. So that is told to them beforehand. So there will be some change in cost also, that is informed to them. And the optometry team who does my biometry, they also know whenever there's significant astigmatism, they call me up and tell, look, he's got astigmatism. I'm taking one more printout where the astigmatism is also correct. I'm very happy with the IOL Master 700, no financial interest. Because I used to use the Verion a lot, which does not look at the posterior corneal astigmatism. And in my hands at least, I'm getting excellent results both in the axis and the amount of toricity with the IOL Master 700 than with the Verion. That has been my experience.
I think you don't need to even let it go through any online calculator.
Absolutely.
The machine
because
itself,
Verion, in our hospital, Verion is a mandate when you go through a femto. So they undergo, if they are a femto, they go through the Verion because we have the lens 6. But even I do that, I use the toric value of the IOL Master 700 and not the Verion.
And the third point was regarding the topography that you mentioned. So that would be a good idea not only to measure the irregular astigmatism, but also for the pupil, I guess, because it invariably gives you the infrared pupillometry.
Yes.
So that may be one way by which you can quantify
you can assess the pupil. Right.
So any questions
Thank
from
you.
the audience? So next we'll have, thank you, Dr. Sai. So next we'll have the keynote address by Dr. Chitra Ramamurthy, Key Intra-Op Pearls for Premium Intraocular Lenses.
A very good morning to one and all of you, and all moderators on the dais for this opportunity to be in this session. So my due is to talk on intra-op pearls for the premium IOL implantation. It starts from the word go, the incision. The incision is so critical, and if you make the neck just at the limbus, near limbus, there's a little bleed that will augur for better healing. You make it a trapezoid incision so that the inner lip is a little bigger, so that the manipulation with the phaco machine in and getting the pieces out and all is sort of better. And the roof and the floor should be symmetric, if equal thickness. These would be the important things. The other thing is, earlier we used to do a surgical induced astigmatism calculation and all. But now, with the use of centroid double plots, what we know is that you need to feed in your power and magnitude and the axis of astigmatism. And when both of these things are done, what you realize is, for any incision less than 2.4 or less, the centroid value or the astigmatism induced is only 0.12, full stop. If the incision is going to be more than 2.4 to 2.8, then maybe the centroid value will go to 0.3 or 0.4. The other thing is, we are talking about effective lens position, the latest formula, where the lens sits in the bag, but the study and other studies have said that there's a change in the anterior chamber depth shift of more than 1 millimeter between 1 hour to 2 months. So although we have hit the nail on the table, Post-operatively, there could be some bag capsular fibrosis or some shrinkage of the capsular bag, which nothing can be done. But intraoperatively, what we could do is get a perfect rexis with the right rexis overlap, do nice nucleotomies without shallowing of the anterior chamber, without exerting stress on the zonules, and do a complete cortical washout. Now, here I've used a radial marker, a 5.5 millimeter round incision is created. I normally would take my cystitome through the side port. Here I've gone to the main port. But look, I'm not pressing on the posterior lip. I don't want the egress of the viscoelastic to shallow the AC and then cause rexis extension. I would keep going back to where the rexis is attached to the primary margin and use that as a pivot and keep moving my wrist so that I get this kind of a nice round rexis. I could use a Varion overlay. So if I have a Varion overlay, I would get that consistent 5.5 millimeter incision and wear my rexis within this outline which is there overlying, and that's get a constant repeatable incision. Now, if I'm on a femtocataract platform, the capsulotomies are either pupil-centered, limbus-centered, or scanned capsule-centered. It gives the three options. Largely, you feed in for the scanned capsule because it scans the anterior lens capsule, the posterior lens capsule. It identifies the theoretical equator, and we need to know that because that's where the lens is going to sit in the bag. And this is how the whole rexis is scanned and planned, and you can get this kind of consistent, repeatable rexis overlap for your premium IOLs. Now, in this particular case, the rexis was okay, not too large, but I have stained it, I have done the rexis, but it is one kind of hard nucleus which is not leathery. And this sizing of the lens is quite enough to remove my entire cataract. But then I feel that future there should not be a capsular bag phimosis. So make just that small tangential nick and just enlarge it just a little bit. So it is about doing premium, whatever surgery, whatever steps you do. As far as the cortical cleaving hydrodissection, it is so critical. You do it in multiple quadrants, decompress, that fluid wave goes, separates all the cortical fibers, and there's less stress on the zonules, and you top it up after decompression, you rotate it, that loosens all those adhesions. So then you get that kind of a very easy, comfortable surgery within the capsular bag. Now, when it comes to your nucleus removal, I prefer to make that small trench and purchase into the nucleus and do a lateral separation. The phaco probe lifts up the nucleus, the second instrument pushes it down, and then you separate. So, but you can see you are able to work at an IOP of 30 or 40, your anterior chamber is stable. It is just the mechanics which is happening. Just that little punch of longitudinal phaco to get buried the fragment, and then all you have to do is just chop it into multiple pieces. So it's essentially lot more mechanics, hardly any ultrasound, excepting that first purchase and just emulsifying it. And your CGE, though it's a fairly dense cataract, is just going up to 3, 4 and all that, which is nothing of consequence. Now, this is a fairly hard cataract, so your pupil is large enough. So make your good 5.5 millimeter incision. Don't err to a smaller rexis. Gentle hydro, yes, you have to decompress each time. You don't want a capsular block syndrome. And then inject just adequate viscoelastic, don't over distend it, and make a small trench if you want, and then separate. Now, sometimes it's so leathery, the deeper fibers are not separating. So you can take your phaco probe, keep it at a lower level, sub-level, in that trench itself, in that chop itself, and separate it and get multiple pieces. Sometimes you don't essentially have to cut it into so many chops altogether. Sometimes if you are able to loosen one piece, you can get that piece out. That itself gives space in the capsular bag, and you just inject viscoelastic and eat it up. Here, however, most of the pieces were created, but as you go down to the last few fragments, you slowly bring down your parameters, because the posterior capsule could be a little lax without the contents, so it could get trampolining into the phaco probe. You don't want that. Now, this is a small pupil. Now you are on the femto platform. What you can do here is, you can enlarge the rexis, which is called a pupil maximized mode. Manually, you are allowed to do it, because you need to be just 100 micron away from the iris. Because if they touches the iris, the prostaglandin release would cause pupillar miosis. But by here, a 4.4 was enlarged to 4.9. and that gives you fairly adequate, and that would extend a little more once you start your surgery. Then it makes it a lot more easier, and you can even have the steps of, there are repetitions of the overlapping pulses that can be cut off, so that the duration of time of doing these steps become far more easy. Now, this is on the Prelex platform. Now, it's a near clear lens. The promises are huge made to the patient. And it makes sense to do them all if you can on a femto platform. But if you're on the phaco, I would do a phaco flip and get out of it, so that I hardly stress the zonules and the surgery is done in no time. Here, what we've done is just a 4 chops. Chops has been done. And the fantastic thing is you get a free floating rexus. You need to just bunch up the rexus, and then you need to use just all you have to do is just a hydrodelineation, which separates up the fragments, and you can just eat it up. I have to go fast. And cortical cleaving, you could do a hydro polish, just inject fluid and loosen up, or just a gentle PC cap polish at a cap vac mode, wherein both the aspiration flow rate and the vacuum is at 10, and irrigation flow rate is very low, and you're able to polish it up beautifully. When it comes to trifocal centration, what is most important is there is an optical center, a pupil center, and visual axis center. If these 3 dots are aligned together, your premium IOL results are going to be brilliant. But more than 0.5, they say angle alpha is not too good. But nowadays, we have large lenses, whether it's a PanOptics or the Symphony or the Synergy, the central optics is larger. So even if your angle alpha is more than 0.8, you can do very well with these patients. When it comes to toric IOL alignment, so you can make the patient sit on the slit lamp just 1 minute and mark the 3 o'clock, 9 o'clock position. And you can even use the ASICO marker to do it with the patient sitting upright and evaluation. If you're on I'm sure most of you know that. So basically, its marking is done already outside. You want to reconfirm it. So place the Mendelssohn's marker on the eye and ensure it's a 3 o'clock, 9 o'clock. And then you use your toric axis. You know where the toric axis is to be marked, and place it on top, and then confirm it. You could use it on a Varian overlay, which makes it very easy. But I'm not going to go into much of it. Only thing, you have to keep after removing all the viscoelastic, you keep it 10 degree away from its final positioning, and then you can position it and see the overlay. Now, if you're doing a hydroimplantation, I like the IOP to go up a little higher, to push it back the posterior capsule, and then inject the lens. And then once the lens is gone in, the IOP comes down, and then all you have to do is to just adjust the haptics in the capsular bag. From 90, it's come to 30. Now, this is the thing which you need to see. It has that small arc, that bulb should come right in the center. So after removing all the viscoelastic, you have those marks on the IOL. So you have to rotate it and align it so that the dotted line comes to overlay that line. But if that bulb comes to the center of that arc, that further confirms that the cyclorotation compensation is complete, and now you are at a near ideal situation, and then you can remove your speculum. You have these intrastromal radial markers at 6 to 10 millimeters for 0.5 to 1.5. So if the pupil is very small, those marks on the intrastromally, that would also allow you to align the lens. So even if it's a small amount of astigmatism, I would use arcuate keratotomies with the Donnell nomograms, which will correct it all. Because when you're doing a premium IOL, it's not forgiving even for small amount of astigmatism. So I'm not going into these special situations, which are each had a tip for itself. But I would like to conclude stating that if we ensure that every step of our surgery from the word go is perfect, not just the biometry and the IOL power calculation. If you do it all perfectly and consistently, your visual outcomes are only going to be optimal at all times. Thank you very much.
Thank you, ma'am.
And yeah,
Beautiful
this
presentation.
one last. I'm sure I've met most of you, but some of you I may have not met. I'm contesting for the post of Vice President AIOS, and be truly obliged if you remember me favorably. Thank you.
So next, I call upon Dr. Minu Mathan to talk to us about the nuances and use of toric IOLs and tips for achieving good outcomes.
Good morning, ladies and gentlemen. Thank you, Dr. Vanishri, for this invite. Most of the toric IOL part has been told by Chitra madam just now. അപ്പോൾ ഇനി വേറെ ഡൗട്ടൊന്നുമില്ലല്ലോ.
So maybe we can even casually discuss on nuances. So the problem actually is big actually. If you look at your K readings, you will definitely see that many, at least 80% of your people will have more than point 0.5. So we are talking about refractive part of it. So if you are talking about refractive part, even point more something above 0.5 will be significant. So this stuff everybody knows, but still we should realize that this is not that very strict. A little bit of misalignment of 5 degrees here and there actually doesn't matter post-op. We have noticed, I have always been checking. They don't exactly fall 173, they'll be little 178 or which is 168 or something like that. But still they don't accept much of a cylinder. So don't be too finicky about this, but then we have to. I will keep on adjusting till it is exactly matching on the table so that some changes which may happen later after all your efforts may be minimal. So online calculator, you can believe your company's online calculator, the brand which you are using, or you depend solely on Barrett formula. So Barrett toric calculator is a pakka freely available website and facility which you can utilize for calculating any of your IOL toric IOL calculator. So pre-op reference marking and intraoperative access marking. So biometry and preparing the patient. Surgery is the same. Biometry and preparing the patient is the most crucial thing. So pre-operative marking, there are many things which are already been told. You can mark it with ink, you can mark it with a marker, whatever. So finally, you should come to a situation that you have identified a step which will give you best results. So what I have identified is make the patient sit on the slit lamp. I have tried this freehand marking, patient sitting in front of you and looking at you and bubble and all those. Very difficult. Once you start becoming presbyopic, you have to lift your head like this, look through your thing. You don't have to do now right now, but then later you will also become presbyopic. And finally, you will have to use this and look at the patient like this. Patient will backload chayum, pinna patient kondu thorannu pidikanam. It's all very the patient is tense when you are close to the theater. I cannot go out to the theater and do all these things. So inside the ward or just before coming in, when they are cool, relaxed, you take them onto the slit lamp and you train 1 or 2 people who can do that, and then mark it on the slit lamp. That is what is best. You can get the best alignment, best positioning of the head and all those things. Because that is the one which will lead you. After that, there is nothing. Unless you have Varion or Callisto or whatever. How many people have Varion? അതൊന്നും ഇപ്പോൾ അവിടെ കൈ നോക്കിയിട്ട് കാര്യമൊന്നുമില്ല. So see, digital thing is beyond the scope of many practices. So there is no point in thinking that digital is the one. We have to depend on the marking, and the marking has to be pakka done. All these things are, I have thrown away all these things. And so make the patient sit up straight and then fix on a distant target, not to converge. And then this is for cyclotorsion, and align horizontally. That is the easiest, because that is the most open part. Vertically always the lid will be there, and so you won't get always exposure. And then 3 and 9 is the best to mark. So the other way is to identify your axis placement mark and then mark that directly. But sometimes it will be vertical and the lid will be covering. You have to lift up. Some people's eyes are small. Patients don't open. They don't cooperate. Many things are there. So mark it horizontally, and then you can use sterile marker. So remember, take multiple companies and see whether the tip is large or small. Some are very large. You make a small dot itself, it will make a 5-degree sized dot. So you are off 5 degrees already. So make sure that you get very fine ones, or you can use a needle and make a fine scratch on the epithelium along the line where you are planning to mark, and then stain it with the blue. Then that will stay. That other smudge will go, so the smudged one may disappear, but this will stay also, and it will mark as the same line. Some people use this hockey stick, this one. There are ones which are a little sharper, so they keep pressing for some time when the epithelium is dry, and that also stays, because a thinner line is the best to have. So it is to align these marks on the IOL, and you know that all the IOLs come with these marks on the haptic optic junction. So this is how we do it. Patient is sitting straight, and you let this one move down or up, and at one point it will cut the light reflex, and so you will see the brightening there. Stop there. Identify, if you want, I try to identify some vessels which are along that line. on the uh, slit, and then remember those vessels and then mark. Sometimes, if you mark many times today, nowadays I am making my postgraduate write how many degrees is the mark off and give it to the person who is marking downstairs. And then daily I at least 4 or 5, they are 5 degrees off, 10 degrees off on one side, other will be correct. So one will be correct, one will be wrong. So you have to train 1 or 2 people and they have to do it properly, or you yourself do. Otherwise the patient will come back to you only if it goes off axis. And then transfer confirm. The point is it should be dry and not to make them blink or tear too much, because otherwise before it dries up, if they blink and then it will go off, patient will come to theatre, lie down there, outside the theatre lie down, inside the theatre they'll block, and then massage ചെയ്ത് വിടുത്ത് അവസാനം ഒന്നും കാണില്ല. അവസാനം അനസ്തറ്റിസ്റ്റ് come and say ആ ഡോട്ടൊന്നും വലുതായിട്ട് കാണുന്നൊന്നും തോന്നുന്നില്ല, താഴോട്ട് വിടണോ എന്ന് ചോദിക്കും after blocking. So അതുകൊണ്ട് make sure that they come off fast after this one, and don't tell them not to rub on this one and all. But originally it has to stay on for some time, and toric is very important. See, now this kind of bigger smudges, bigger marks are the classical things which you get. So please identify small ones. So then again, drying this up is very, very effective. Madam touched all these things, but it was too fast. I am going it very, very slow. And then have this one. I have 2 printouts. One is in the case sheet and one is stuck onto the microscope. So you will never go wrong, because flipping or changing other eye eduthu vekka idokke are very common. And axis also, please remember, before you calculate or finalize your thing, look at the printout and compare it with what you have. I always do if it is more than 0.5 in your lens star or anterior, I get a topography done, and then from there you calculate it on and get a printout and keep both these together, and I have asked them to bring it back to me. I will compare whether this has been transferred correctly. Sometimes one axis will be flipped and the 90 degree will go 180 degree and nobody will realize. So you have to confirm it, and then I sign on that paper, and without that sign we don't let patient come inside. And then we stick it onto that and look at there. And so, and use this one. See, sometimes if there is ballooning, if it is blocked, there will be ballooning of conjunctiva. Please wipe off all the what is that, chemosis, and then place this one properly. See, this one again, the placement has to be exactly around the limbus. If one side is more, you may go wrong. So, and identify and dry it very well, and then mark. The fluid will collect here. No, so that is what happens if you don't dry, and your mark also will get smudged. Use a very thin one and then mark. And also if you are blocked, make sure that your central point is also marked, and it this mark goes through the Purkinje image, and then use this. This is the longer one which I use, because we want the mark to come onto the cornea rather than very peripheral marks, because the lens is 6 millimeters and the marks are around 5 millimeters. Because one speaker is not available, I will take half a minute more. And once this is placed, this is an Indian IOL which I am showing. You can use any IOL, but monofocal correcting astigmatism is very, very important. More than 0.75 I will correct for any monofocal. EDOF and multifocal, it will be 0.5. From there you start, and if they are not willing, it is up to them. So as Sai said, they will get എന്ന് പറയാൻ പറ്റില്ല, because cost is quite high if you compare multifocal toric and regular multifocal. But they will have to be told very vehemently that this is going to reduce your uncorrected vision drastically, and so don't blame me, and get it signed from them if they don't want. So I use nowadays hydro implantation. That's very good, but still you have to wash. If you are folding the lens in visco, wash the lens again, even if it is hydro. But if nowadays I am implanting especially Alcon lenses, I am folding it under BSS, so no visco inside the cartridge also. But still, always wash. It is important to wash the equator also, because it's the outer part of the haptic which is touching the equator, and that is where it has to stay. IOL just along the optic alone is not enough. So go outside beyond the rexus margin and wash close to the equator, and then make them parallel. Both on one side is same, okay. But one on one side and the other mark on the opposite side is not a great idea. That should not be. So these two, and these lines, use lenses which have longer marks. One spot, there are lenses with one spot. That is very difficult to align. Sometimes the axis will go 5 degrees, 7 degrees off. So we know this has been already shown, measured twice. So this is the femto. Fine, nobody has femto, so don't see. Thank you very much.
Thank you, Dr. Minu.
And next I call upon Dr. Swapna Nair. She'll be talking on refractive surprises after cataract surgery, understanding the corrective strategies.
Get your breath, Manashri.
Sorry, I
She
had
has
to
been
get two
running between
places.
halls. Yeah. So thank you very much for having me for this talk. So now that you have done the perfect refractive surgery and you're all happy about it, we are going to talk about a circumstance when the patient comes back to you and he's extremely unhappy. So I think these are some of the things that we have already touched. The surgeon-induced astigmatism, the measurement of both the anterior and posterior corneal astigmatism, the effective lens position, and the various formulae required for multiple things. Now, this is the first point where you're going to go wrong. So all these things that elevate your cataract surgeries, the multiple data that you're able to incorporate into a Barrett toric calculator can be your downfall as well if the data is not acquired properly. So even a 0.1 millimeter change in the axial length can produce a 0.27 dioptric change in the intraocular lens power calculation. 1 millimeter ACD change can produce a 1.44 diopter change in your intraocular lens power calculation. We already know the effects of dry eyes and K values. So now if you have a tool, we already talked about Sia, I think she has explained it very well. So if we have too large a capsulorhexis, we know the lens can tilt. If it's too small, it can contract and cause posterior bowing of the lens. And this posterior bowing can induce some amount of hypermetropia, which is very, very dissatisfactory to the patient. Myopia, they will tolerate, but never hypermetropia. So this is roughly the amount of tilt produced by various decentrations of the capsulorhexis, as was done by this study, and it is important to avoid that. Now, in case you land up with a refractive error, in spite of doing all these properly, how do you go about it? So very small errors which are caused by malrotation of the IOL, or provided you haven't put a toric IOL in place, like Dr. Minu had recently mentioned how to align them properly. It was off axis, your axis marking was wrong, or maybe afterwards you find that it has rotated a bit, then you can of course go to this website and get the exact amount of rotation that needs to be done to bring about the IOL into position. Now, in case you have something which is not rotation but a residual error, either spherical or cylindrical, one of the earliest or the most non-intraocular treatment that can be done is laser vision correction. So I always prefer a surface ablation because I'm not going into the cornea, I'm not applanating the cornea, putting pressure on it or cutting a flap on an already operated eye. So this I'd be doing at around 1 month of a stable refractive error. This is very good for small refractive corrections like small amounts of myopia because the patient ends up very satisfied after that. And the error should be stable, your topography should be normal. That's very important because a lot of cataract surgeons who are not into refractive surgery don't mind the topo. But please do a proper topography so that you don't land up with ectasia or higher order aberrations or maybe a lot of dry eye that may not be suitable in an older population because most of our LASIK candidates, most of our refractive surgery candidates are young people and dry eye is marginal in them, but not for an older population. And avoid very thin corneas just like you would avoid them in any form of laser. So this is how surface ablation works. So this is the patient lying down after draping and the laser keeps on firing. You're not touching the eye other than to place the mandatory mitomycin for a short amount of time. So this is one procedure I definitely prefer for any patient who has undergone an intraocular surgery. Now comes the second option. So this is usually for a larger amount of error where there are multiple indications that have been noted, and a lot of IOL decentration or dislocation. When an incorrect IOL has been placed, there is no option but to take it out, especially if the error is large. And this also has been done in a lot of people who are intolerant to multifocal intraocular lenses. So, or maybe they expected too much beforehand and then they have landed up with some kind of an error. So, and it's always done close to the primary implantation before all the, sine K or all the capsular adhesions have taken place. And it's very important to identify the exact cause which has resulted in that residual, because if you don't identify it, you may go wrong again with the secondary implant that you're using. And always watch out for late surgical complications. You cannot do it in an eye which already has a zonulodialysis or a tear, and always look out that even when you're implanting, you can induce all these complications. So here, this is a patient in whom the surgery had not gone well, and there was an implantation of a rigid single piece lens in the sulcus, and that was producing constant uveitis and +5 diopter sphere of hypermetropia. So this is one procedure that I'll use for a hypermetropic error that is not very small, instead of doing a laser vision correction. Because of the extreme steepening of the cornea that's brought about by the laser vision correction, that produces a lot of aberrations, which is definitely avoided in such a circumstance. So here, there goes a 3-piece intraocular lens, which is absolutely suitable for the sulcus, into the sulcus after removal of the single piece intraocular lens. Now, now comes another important thing that is not usually discussed in our fora, that is a piggyback IOL. It has been underestimated a lot, is what I feel. So this is actually a sulcus or a capsule IOL over and in the bag lens. So it can be done as a primary polypseudophakia, where you implant one lens and to correct the residual part that your manufacturer may not be providing. So suppose you have a lens of 39 diopters that's required. Most manufacturers give only up to 30 diopters. So the rest of the 9 can be used as a secondary IOL in the same surgery on top of the first one. That is primary polypseudophakia. But here we are talking about some variable eyes like keratoconus, where the powers may keep on changing. Pediatric eyes, again, which may develop myopia. Eyes with silicone oil, which will need another kind of lens in front, and in presbyopia, if you want to correct the presbyopia later on with another lens. So the same indications as the IOL exchange. It's technically easier because you're putting another lens nowadays only in the sulcus. Nowadays, we don't put a piggyback IOL in the capsular bag due to many reasons. The IOL power calculation is much easy. You can use either a Barrett treatment calculator or a shortcut like I've mentioned over here. In case your ametropia is myopic, then this is the calculation that you add to the implanted IOL, and if it's hypermetropic, the second is the calculation that you add to the IOL. So these are different types in use. Even the piggyback lenses like the Sulcoflex can provide you trifocals and a lot of options, torics. That is the add-on lens on the other side with the 4 haptics. Then you have the Crystal lens Reverso, which is again a multifocal lens. And then you have the extra focus is from Mocha. It's basically a one with an iris diaphragm, and it works by the effect of pinhole. That does reduce irregular astigmatism along with correction of the ametropia. Now, when do you not do it? When the zonules are loose, because you don't want to put another haptic into that sulcus, where the zonules are. When they're posterior synechia, that's a relative contraindication. Broad ones, absolutely no. And when the endothelial cell count is very low, very important that you do a specular before you implant a secondary IOL. Now, this is an add-on sulcus IOL that's being implanted. So you can see that there's already an IOL in the capsule. Most important thing is that you cover the place with viscoelastic, not only in the anterior chamber, but underneath the iris, where you need to put small aliquots of viscoelastic in these places where the haptic is going to stick in. So here, an add-on sulcus IOL is being implanted. It has 4 haptics, and this goes in just like a phakic IOL with the plate haptics. So you put the intraocular lens, you use the same incision that was made for the initial cataract surgery. And this can be done later on also, not immediately, but suppose you want to wait for a while before you do secondary procedure. That's also done because you're not disturbing anything, taking anything out, just putting another lens in the sulcus. So it is gently placed in the sulcus and aligned with the primary IOL. Now here is another one where a 3-piece lens is being implanted into the sulcus. So you have already one sitting there, and there goes the 3-piece lens for the added refractive error in the sulcus. Again, both haptics are dialed in and the viscoelastic washed out. Now here is a multifocal intraocular lens that is being augmented by a low power IOL because of an error in the target refraction. Now, what is important, what you see over here is the clearing up of the viscoelastic from, under the lens and over the lens and in between the two lenses. So these are the ideal characteristics that a lens, piggyback lens should have. And these are the side effects that can be produced, especially because this lens is going into the sulcus. It may irritate the iris, it may irritate the zonules. Uveitis, glaucoma, hyphema syndrome is a small possibility, not much with the modern lenses. Now, this is something I just wanted to highlight. It's called interlenticular opacification, where there is proliferation of Elschnig pearls in the interface between the two lenses. This is where it becomes important that you don't put the second lens into the capsular bag, but in the sulcus, because you need to keep the two optics away. And in case that does not happen, that's when you get proliferation, can be divided into multiple stages, and there could be total opacification adherence between the two lenses, which is very, very hard to treat. It's not common, but once a lens comes in the sulcus instead of the capsular bag, you can see how a large capsulorhexis aids in this. So a large capsulorhexis would, fall back on the haptic of the lens and prevent proliferation from the fornices of the capsule from passing into the interlenticular zone. So another method that has been suggested is that one of the lenses have a slightly concave surface, so that it doesn't get adherent to the other lens. So to recap, any kind of post-cataract refractive error can be corrected by multiple methods. Now, whatever you're going in for, always remember it's the patient's choice. You can always ask the patient to wear a pair of glasses if you feel that they are not the right candidate or will not be satisfied by all the, big things that you're going to do to correct this small refractive error. Thank you very much.
Thank you, Dr. Swapna. That was interesting. Ma'am, I would like to ask one question. You said that a small myopic error you will correct after a month. So, do you really do you always prefer around a month, or because sometimes the point I wanted to highlight actually was if there is a capsular distension, and we are suspecting that, what would be your thought around that? Would you wait for some time or?
Yeah, so if there's a capsular distension, I'll just yak the capsule and take the viscoelastic out. That's what I'm going to do. I wouldn't wait for it to get absorbed by itself. Now, it's very unlikely that I'll get a myopic refractive error with a capsular distension, because I wash visco. I literally, take a mop and scrub and clean, and other than the endothelial cells, I take everything out. So that is maybe something that needs to be ruled out. But in all other cases, I'm just waiting for a little bit of stability, because I want to know whether there's any residual astigmatism as well that should be treated along with the myopia.
So a month should be good to go.
I think that's actually 2 to 3 weeks is also pretty good with all the modern methods and all the small incisions that we're using.
Okay. Okay. Any questions from the audience? Thank you very much. Yeah. Thank you very much, everyone.